You can go live now.
Good afternoon, doctors. On behalf of Hitro Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on troubleshooting PCOS. Doctors, as you know, at Hitro, we market products in multiple therapy areas like in gynecology, dermatology, orthopedics, pulmonology, etc. With a very strong R&D support and background, we have developed many products, many unique formulations, keeping patient benefit in mind. Our endeavor is to develop products, formulations, and combinations which will finally improve patient compliance and ultimately lead to a better clinical outcome. We have developed NSAID patches, rivastigmine patches for better patient compliance. At Friends Art Division, Doctor, gynecology, obstetrics, and IVF is an important therapy segment for us. We market products for vaginal health like Feminora, Belitra, etc. We have formulated and introduced vaginal film containing lactic acid. In oral formulations, besides Didropal and other formulations, we market Mylotin. Mylotin, doctors, is a unique nutraceutical for PCOS management containing myoinositol and dechiroinositol in a ratio of 40:1, along with chromium picolinate and melatonin, folic acid, and vitamin D. But to speak more about PCOS and management with nutraceuticals, we have Dr. Tanuja Joshi today. Welcome, Dr. Joshi. Welcome to this webinar. Dr. Tanuja Joshi is MD DGO, is a consulting gynecologist, medical director, Srinivas Hospital, is an empaneled gynecologist in Aditya Birla Multispecialty Hospital, Surya Hospital, Sterling Multispecialty Hospital. Over to you, madam. Welcome once again.
Thank you. Is my screen visible to all? Hello? Hello?
Yes, ma'am. Yes, ma'am.
Yes.
Yes.
So shall I continue?
Yeah. Yes, ma'am.
Yeah, thank you, doctor, for grand introduction. I am Dr. Tanuja Joshi, practicing in Nigdi, Yamuna Nagar, Pune. Today, I am going to speak something about troubleshooting PCOS. Just a minute, and the slide is not going. May I? Can somebody help me? Hello.
Okay.
Yeah. Now it's
Yeah,
yeah. So, as you all know, PCOS is the most common hormonal abnormality in women of reproductive age group, which affects around 5 to 10% of female population. And the prevalence is very high in adolescents. And it is typically characteristic that the insulin resistance is found in 76% of PCOS women. So, practically, if we see in OPD, every 1 in 5 women in India suffers from PCOS. So what is PCOS? Like all the gynecologists know what the PCOS. It is a common endocrine disorder which affects the women of reproductive age group. And this is typically characterized by hyperandrogenism. There could be some ovulation disturbances like anovulation, oligoanovulation. Then it also has got a PCO morphology on sonography. When we do transvaginal sonography, we can see the follicles which are arranged peripherally in necklace pattern, and the size of it is roughly 8 mm. So typically when we do such sonography on day 2, day 3, we can see all these types of follicles. Also we can see it, but in cases of infertility, we typically see the do sonography on the second day to count the antral follicle count. So women with PCOS, they are having menstrual irregularities, and they have got a varied presentations. Like they also face many metabolic disturbances in future, like cardiovascular, type 2 diabetes, visceral obesity, endothelial dysfunction, and they are more predisposed to the cancer risk because of the estrogen excess in such patients. So PCOS, it is not just a cosmetic problem. it has got a fertility problems also associated, and this may pose health problems and may reduce the life expectancy because of the metabolic disturbances involved in PCOS. So these are the health issues which are commonly faced by women, which are infertility, weight gain, obesity, metabolic syndrome, cardiovascular diseases, dementia, then endometrial ovarian cancers, breast cancers. Then there is a typical one entity. When we do sonographies, we find fatty liver, that is non-alcoholic fatty liver disease, which is also not very good for the expectancy of our life. The additional obesity linked diseases, like these people, they are more prone to get osteoarthritis, osteoporosis, and during reproductive age group, they are more prone to have miscarriages, gestational diabetes, low birth weight, and preterm labor pains. So what are the typical signs and symptoms? So there is a weight gain, which is very difficult to manage. There is a fatigue, poor sleep. The sleep apnea is present in such cases. There is a hirsutism. There typically the distribution is around face, arms, back, chest, thumb, and abdomen. There is alopecia, which increases with the as our age increases. The infertility is also there. The acne, skin tags. Then typically one condition which is called as acanthosis nigricans. It is because of the increased epidermal hyperkeratosis and dermal fibroblast proliferation. This is particularly seen over the nape of the neck and axilla. So that is characteristics. When you see the patient and observe these types of findings, we can easily say that this patient is having a PCOS. Then there are different mood swings are found in such cases. They are exposed to anxiety, depression problems. Some patients they may present with the menorrhagia because they are having irregular menstruations. Suppose if the patient is having amenorrhea, and once the withdrawal bleeding starts or the spontaneous bleeding starts, it continues for many days. Sometimes patients come to us with many months also the patient is continuing with the bleeding. It may be spotting, it may be in more in amount, and because of this the patients they are found anemic also. So whenever a patient with PCOS comes, we have to think of this hematological aspects also. So what are the qualifying criteria for PCOS? So there are different societies or the bodies which have given the certain criteria on which basis we diagnose the PCOS. Commonly we follow Rotterdam, the NIH, and androgen excess PCOS. In this, whatever the green ticks are there, these two has to be there. So anovulation, oligoanovulation, hyperandrogenism, and polycystic ovarian morphology are the common things which are found in PCOS and are necessary to diagnose these patients. So if we consider the phenotypic classification is based on classic PCOS in this phenotype A. So there is hyperandrogenism, chronic anovulation, and there is a polycystic ovarian morphology. The phenotype B is having normal ovaries along with the hyperandrogenism and chronic anovulation. Ovulatory PCOS phenotype C. In that, the patient is having hyperandrogenism, PCOM, and ovulatory cycles. And phenotype D is normoandrogenic, in which there are no clinical signs or biochemical signs of androgen excess. So typically, if we see in this pie chart, the phenotype A is more predominant in the PCOS population. And BMI plays an important determinant of metabolic abnormalities in all phenotypes. But they have got enhanced importance in phenotype A and B. Suppose if we think of the genetic and ethnic variation on the broader perspective, so you can see the UK, USA has got a lesser incidence of PCOS compared to South Asians and Mexican Americans. So the prevalence is more common in the South Asians. Accordingly, in this geographic distribution, what you can see, the South Asians, they have got a more severe metabolic syndrome, and those in USA, UK, they have got a hyperandrogenism associated with this. When we consider the pathophysiology, the genetics play a role. When it is a complex disorder, it has got a genetic as well as environmental factors. when we see the patients, 20 to 40% of females first degree relatives, they have got this syndrome. So prevalence and severity of presentation varies along with the ethnicity as well as some genetic contribution is thought of. Then intrauterine exposure of testosterone. In animal studies, it has been demonstrated that the fetuses, if they are exposed to testosterone, they are likely to develop PCOS-like syndrome in future. So similar pathophysiology can be attributed in females too. Environmental and lifestyle. Lifestyle plays a huge role in PCOS. Like sedentary lifestyle, it is associated with the increased metabolic dysfunction, and when there is a weight gain, then it is associated with the hyperandrogenism. Environmental and androgen disrupting chemicals, they may accumulate in greater extent in individuals with PCOS, and these induce androgen production and insulin resistance. The obesity itself is not a cause, but it exacerbates the symptoms and signs of hyperandrogenism because of the hyperinsulinism. So the basic abnormality is there is an abnormal gonadotrophin secretion. Initially, it was thought of increased serum LH and FSH levels. There is an altered LH-FSH ratios. So this is more common in lean PCOS than the obese one. And gonadotrophin levels or ratios, they are not a very reliable diagnostic criteria, but is a common association in most of the PCOS patients. So dyslipidemia, as I just discussed that there are metabolic abnormalities are found commonly in PCOS patients. So dyslipidemia is also a common metabolic abnormality. Nearly 70% have at least one borderline or elevated lipid levels. Insulin resistance and hyperinsulinemia, they are associated with decreased HDL and elevated triglyceride levels. The insulin resistance is found in between 50 to 75%, and it is more common in obese than in lean women PCOS. Most women with PCOS and insulin resistance, they are young. In this, the anovulation we can see because the granulosa cells of anovulatory ovaries, they produce around 75 times of more AMH, and this AMH has got effect in reducing the expression of FSH receptor mRNA, and this AMH inhibits the effect of FSH on the receptors. And when they cross the 10 mm, then that inhibition is lost. So higher the AMH, the greater the ovulatory disturbance is found in many of the studies. So this is a possible role of AMH in the anovulation. This is just a statistics to show how many PCOS patients have got particular abnormalities. So if we consider the androgen excess is found in more than 80% women, oligomenorrhea is found in 85 to 90%, amenorrhea is found in 30 to 40%, hirsutism is found in 70%, infertility is in 40%, spontaneous abortions are found in 42 to 73%, and 90 to 95% women are anovulatory, which report to infertility clinics. So you can see how the PCOS is important in clinical presentation, and that is why we need to take care of the PCOS in the beginning only. So what sort of investigations can we think? So these are the investigations which we would like. But in my clinical practice, I usually advise patients AMH, SHBG, total testosterone levels, serum prolactin, TSH levels, LH, FSH, and fasting serum insulin. And typically this profile we usually do on second day or third day of the periods because that gives us the correct clinical picture. So the recommendations is the choice of the proper line of therapy depends on every patient. Like we cannot, the therapy is not tailor-made. We have to adjust it according to the patient's age, at what stage of life the patient is in, what are the symptoms, what are the personal and familial risk indices, and her choices, what are her preferences. So initially only I said, and I still repeat, the lifestyle modification is the most important tool, and we must insist the patient Because nowadays, because of the urbanization, and even in the rural areas, the urbanization has reached, the lifestyle has become very sedentary, and because of that, the PCOS problem has cropped up in all the areas, including the urban area as well as the rural area. So we must give more emphasis on the lifestyle. So what we must say, the patients or the individuals, weight reduction and exercise. Obesity worsens the endocrine profile and it increases the risk of infertility. So to improve the ovulation and improve insulin sensitivity, lifestyle modification plays the most important role. What are the other molecules or pharmacotherapy which we can use is the metformin, combined OCPs. Indian PCOS is very different and we need to think of some other molecules along with the lifestyle modification. So when I practice, my first aim, like when the patients, they come to me for infertility, my basic aim will be to have a live birth, not just that her menstrual cycles are getting regulated, hirsutism. That is a byproduct of the results of our therapy, like whatever the pharmacotherapy or lifestyle modification we are giving to the patient, that naturally improves the oocyte quality and thereby the result. So live birth is the correct outcome of all the clinical trials when we evaluate the therapy for infertile couples or the patients presenting with the PCOS. So the goals of treatment, it could be regulation of cycle, improving insulin sensitivity, reduction of weight, improve fertility and decrease androgen levels. Today, 80% of the PCOS market is captured by multiple combinations of MI and DCI with different claims, which can encourage clinicians to use them in PCOS treatment. The advantage of this molecule is it is quite effective and they are better tolerated. I have found good results with these combinations. So, what are the current gap in PCOS treatment? Lean PCOS is only for correction of PCOS, infertility PCOS. In this, we have to do the correction of PCOS as well as ovulation. Obese PCOS, we have to correct weight loss also along with the correction of PCOS. Insulin PCOS, we have to improve the insulin sensitivity and hormonal imbalance. We have to see correction of the hormonal cycles, regulation. None of the formulations are giving complete solution. So, what are the ingredients and what are the benefits of them? So, when we think of MI-DCI, when we use it in the 40:1 ratio, it regularizes the menstruation, it improves egg quality, it restores ovulation. Chromium picolinate, a new molecule, it improves insulin sensitivity. Melatonin improves oocyte quality. Vitamin D3 and folic acid, they too help in improvement of the ovulation and improving the oocyte quality. So these are certain molecules which are very good in the therapeutic treatment. So myoinositol, dechironinositol. So in PCOS, when we see there is a 500-fold decrease in myoinositol levels of the ovary, and because of this, there is a impairment in the follicular development. When we use combined MI-DCI, it is found to be extremely beneficial. And dechironinositol, it typically reduces the insulin resistance, it improves insulin sensitivity, and myoinositol also has got a role in ovulation. So there is a rationale in combining these two molecules. Myoinositol acts at periphery in this pattern. There is a decrease in free fatty acid release and increase adiponectin release, which diminishes the insulin resistance. And then inositol triphosphate releases and it modulates the intracellular calcium release and it improves the oocyte quality. So what are the benefits of MI-DCS ratio 40:1? I actually have discussed. There are two stereoisomers of inositol and insulin sensitizers. MI is a second messenger in FSH and MI mediates FSH signaling. DCI is an aromatase inhibitor and this allows the treatment of PCOS. And these are reliable in improving the menstrual cycle. It improves the acne score, the endocrine and metabolic parameters, and the insulin resistance. So these are basically helpful in correcting the pathophysiology of the PCOS, and thereby we get the good results in practice. So this particular molecule, chromium picolinate, this chromium is combined with picolinate because it increases the gut absorption. And when given in PCOS patient, it reduces hyperinsulinemia, hyperandrogenism, which are the basic pathophysiology in PCOS patients, and thereby it improves insulin signaling, it improves insulin sensitivity, it also helps in fat loss. And the advantage of chromium picolinate is that it is better tolerated than metformin. Metformin, along with that, we do find nausea, and the patient says that there is a diminished food intake. So in such cases, I think chromium picolinate is good alternative rather than metformin. So the combined action of both inositol and chromium picolinate will help to treat the underlying cause of PCOS. So these are different studies where the chromium picolinate has been found to show the results. This is again a study related to the chromium picolinate and metformin use. In conclusion, it is said that chromium picolinate is better tolerated than metformin due to lower side effects, and it improves the oocyte quality, thereby improving the pregnancy rate. And now one molecule which is much talked about is melatonin. So addition of melatonin, how it helps in PCOS patients? It has been found that the concentration of melatonin in pre-ovulatory follicular fluid is lower in patients with PCOS. So it helps in nuclear maturation of oocytes. When this melatonin particularly was studied in vitro, the melatonin administration is useful in IVF patients. When we implement in patients who are undergoing IVF cycles, they improve the clinical outcomes in regard to the live birth. So melatonin is used in many cases of IVF patients. Therefore, this melatonin is helpful in improving the oocyte quality and increase pregnancy rate. It is also found that it is a sleep-inducing hormone. So if with proper sleep, if there is a less sleep apnea, the quality of sleep is better, and automatically the stress levels reduces in patients with PCOS. And many of the things are related to the deprivation of sleep. With the improved sleep pattern, the patient feel like doing some exercises, and this is an added advantage that they can sort to the exercises. Okay, so these are the different trials conducted. In all the trials, it has been found that melatonin improves the oocyte and embryo quality, and thereby increasing the results of live birth rate. This is the trial 2. This is the trial 3. In all this, the clinical management of PCOS, these were used, and it is found this is a pineal hormone. So this pineal hormone melatonin, it has earned a serious attention for clinical use in management. It leads to improvement of oocyte, ovarian functions, oocyte quality, metabolic and hormonal profiles. So it has got multiple advantages. So it is better that we can add melatonin to our armamentarium in our pharmacotherapy. There are added advantages of folic acid and vitamin B3 in improving the oocyte quality, and also it has been found that those patients with PCOS, their vitamin D deficiency, there is a deficiency in vitamin D, so there is always an added advantage of adding vitamin D3 to our pharmacotherapy. So I think, shall I take the case study now or later, ma'am?
No, ma'am, you can take it now. You can share your
take
Yeah.
it.
Yeah.
So
Yes.
in my clinical practice, I have used Mylotin in a few of the patients, but I'm discussing some 5 cases where I really found good results. The results are encouraging, and I have kept them on this patients, and I'm adding many more patients with this regime. So these are the A, B, C, D, E are the patients. These are the basic investigations. When I started with the therapy, like when patient presented to me, of course, these patients are a combination of having amenorrhea, some were having irregular periods. The menstrual cycle was so irregular, like 3 to 4 months they used to get it. they were getting it. Then there were some couples who were interested in having pregnancy, presented with primary infertility, secondary infertility, and one or two patients who were having more testosterone levels, they were having hirsutism and as well as the acne problem. And I have given them this therapy for 6 months. And with that, I have found drastic results in the biochemistry. So I found it quite helpful and encouraging. So like the patients who are not exactly like actually interested in having conception, we can just add mylotin, and along with that some hormonal therapy if required, depending on their menstrual irregularities or other problems. We can add drospirenone, all those things if required. Otherwise, simple adolescent PCOS patients, we can just add this, see the results, because they are not in a hurry to have any pregnancy or anything. They are not running short of the time. So I think we can, young girls, we can start adding this and see the results. Okay. So nowadays, the whole practice is evidence-based, and our efforts has to give a live birth. So even if the adolescent patient comes to us, it is our duty that they don't get trapped in the cycle of PCOS. Like they come for many months, like they will come take a cycle of hormonal therapy or these non-hormonal medications and repeat it after again 1 year with the same problem. So the importance of lifestyle modification along with the pharmacotherapy is there. So I just want to mention this molecule. Everybody knows metformin, but I use this when I find the fasting serum insulin levels excessively high. Only in those cases I add metformin. Otherwise, I go for the insulin sensitizers only. So everybody knows the mechanism of action of metformin. I'm not going to go into detail, but in short, if I say, it improves the anaerobic glucose metabolism, it decreases gluconeogenesis, decreases glycogenolysis, thereby decreases fatty acid oxidation and decreases hyperglycemia. And it also acts on the skeletal muscles, increases glucose uptake, increases glycogenesis, and decreases fatty acid oxidation. So these are the properties of metformin. Then and it has got additional actions like anti-obesity, anti-hyperglycemic effect, thereby it also improves some of the PCOS symptoms. It has got an anti-lipidemic effect, anti-diabetic protective effect, hepatoprotective effects, cardioprotective effects. So the cumulative effects results in the decreased weight gain and a better lipid profile. So I have discussed the inositol. It plays by restoring the LH-FSH ratio. It reduces the testosterone levels, restores normal ovulatory activity, fertilization rate, improves insulin sensitivity, reduces the lipid profile, decreases the or improves the lipid profile. So what is your judgment? Medication that addresses conception or just conception with live birth? So our aim has to be conception with live birth. So here I would like to give you the take-home message. Ethnicity is strongly associated with prevalence of PCOS, which is higher in India. Asian Indian women, they have got an early onset of PCOS, early ovarian aging. So we need the treatment at the early age. Majority of Indian women, they have got insulin resistance. They have got higher fasting insulin levels, low SHBG levels. And we need to have a different treatment approach for each individual. The treatment should, as I just said, it is not a conception, but it should focus on a conception with live birth rate. And the practicing evidence medicine is the important way that offers to translate our efforts, our clinical efforts into live birth. So thank you very much for giving me this opportunity. Yeah, over to the moderator, sir.
Thank you very much, madam. Lovely insights, we got, especially those 5 cases which you described. I mean, they gave a lot of insights. Now, my question is, with the different type of PCOS, like reproductive, metabolic or psychological, in which specific type of PCOS would you prefer this combination?
This particular molecule?
Yeah.
I think it has got role in both. It
All
can
three,
be as an adjuvant in metabolic.
Of course, yes.
Also.
Mainly this particular thing will go as an adjunct to along with other specific therapies.
Other hormonal therapy.
Absolutely.
Because the presentation is severe, we have to use a...
Absolute.
combinations as well.
Madam, is a type of PCOS weight related or age related?
PCOS.
Yeah, the
Uh,
types.
Actually, initially to begin with, when the menarche starts, the thing is that because of the latest urban lifestyle, these typical girls, they get entrapped in this PCOS cycle. So I can say it is age related also, but more commonly we present middle age group because they have got added responsibilities, added stress also, which increases the chances of their anovulation and oligoanovulation and all those things. So the lifestyle plays a major role that precipitates the which is latent PCOS that actually manifest because of the environmental factors.
I mean, you have spoken about this ratio of minoinositol and dechiroinositol 40:1, the physiological ratio. The ratio would matter, of course. Inositols have got a physiological role. And melatonin and chromium, what do you feel about their role in insulin resistance? You have said that, but would this melatonin thing be common in patients because they work in shifts, they work in call centers, etc.? Would this become relevant there in those patients?
Actually, in that case, we have to adjust the timings of dosages.
Okay.
At what time we give, because the increased melatonin levels, like if we adjust according to their bedtime, that will give us the better results. Because at the end of the day and in the beginning of morning, melatonin levels are slightly on the higher side and has got a good effects if that is given at that time.
And it will have little
adjust the timings.
It will have little sedative effect in any case, melatonin. Yeah. How soon? Now you said that laboratory results you got after 5-6 months, but clinical response you see it earlier as compared to.
It is almost simultaneous, I can
simultaneous.
say. Menstrual regularities we do observe in 2 to 3 months.
Okay.
3 months, I can say.
And how long would you typically prescribe this product?
I think in my practice, I usually prescribe it for 6 months. Like suppose if I add hormonal therapy, it is an adjuvant along with the hormonal therapy for the first 3 months. And the next 3 months, I just give the adjuvants, just this insulin sensitizers, not hormones. And with that, along with that lifestyle modification also, I give more stress on that too. So they do get good results by the end of 6 months.
Correct.
Some people I've seen, like some patients, they have conceived on it. Like even I have not put them on the ovulation inducing agents. And the 7th, 8th month, they come with the conception, spontaneous conception.
That's great. You think that this particular type of products, the nutraceutical, they will have a role before IVF procedure?
Of course, it has to be tried because IVF is quite a stressful event in a couple's life. So I think we should always try.
Give it a try.
We must give a try.
Gut dysbiosis is a lot spoken these days about gut dysbiosis and PCOS.
Yeah.
So, I mean, of course, this will have no role there, but a gut dysbiosis does play a role. So, lactic acid formulation will also be co-prescribed, could also be co-prescribed.
Yes, we can add. Yes. It's a new line of management.
Yeah. Thank you, doctors, for this wonderful insights, And I thank all the participating doctors who took time from their busy schedule and commitments and attended this webinar. Thank you, marketing team Hitro, for conceptualizing and organizing this webinar. Also thank the field personnel of Hitro, without whose support this type of program cannot be possible. Last but not the least, I thank IT team of Hitro for your support and guidance in all technology-related matters. Once again, thanks all of you. Signing off, wishing you a very pleasant evening. Thank you once again, madam.
Thank you. Welcome.